line of defense, the immune system. It's protection against any type of invasion. Even if the body, it's not an invasion, the body thinks it's an invasion. Homeostasis. It's damaged cells that are digested and removed. That is the auto-regulation of the body. Surveillance. Mutated cells are recognized as foreign and destroyed. So surveillance and defense work hand in hand. This is the lymphatic system, the diagram, and it's showing you the different areas of the lymphatic system. The tonsils, the right lymphatic ducts, the thymus glands, the thoracic ducts, the spleen, some of the lymph vessels, lymph nodes, and the bone marrow. So, quickly, functions of the, so organs of the immune system. You have the tonsils, like I mentioned. You have the lymph nodes. Functions of the lymph nodes include filtration of foreign material and circulations of lymphocytes. The spleen. The spleen is the primary site for filtration of foreign antigens from the blood. So, if the spleen's enlarged, aka splenomegaly, you know that something's going on where it's working over, it's overacting, and it's working hard to take all the foreign antigens from the blood. The thymus gland. Both the thymus gland and the bone marrow are the central lymphoid organs. They're the main ones of the lymphatic system. The thymus gland produces T lymphocytes. During childhood, it's very large, but that's normal for it to be large during childhood. The bone marrow is where lymphocytes are produced. The tonsils, lymph node, spleen, bronchial-associated lymphoid tissue, skin-associated lymphoid tissue, the gut-associated lymphoid tissue, and the genital-associated lymphoid tissue are all peripheral lymphoid organs. Once again, the bone marrow and the thymus gland are the central lymphoid organs. A homeostasis is a state of equilibrium in the internal environment of the body. Humoral and cell-mediated immunity. Innate immunity is present at birth and is the first line of defense against pathogens. Acquired immunity is the development of immunity. It can be active or passive with each reinvasion of the microorganisms, and the body responds more rapidly to fight off the invader. Each reinvasion could be as a result of two things, either vaccination or immunization or disease. So getting the disease again or whatever, getting the virus again, getting the bacterial infection again, just producing those antibodies. An antigen is a substance that elicits an immune response. Immunity. Humoral immunity is an antibody-mediated immunity. Antibodies are produced by plasma B cells. There's 5 types of immunoglobulins: IgG, IgA, IgM, IgD, and IgE. They are all secreted by plasma cells. IgM is the first type of antibody formed. IgG is the primary antibody found in a secondary immune response. This is when the patient already has antibodies. Titers can measure IgG. That's the only one titers can measure. IgA protects body surfaces. IgE causes symptoms of allergic reactions. And cell-mediated immunity is initiated by T cells. IgG, once again, 76% of it is serum concentration in the interstitial fluid and plasma. IgA is 15%, which is in the body secretions, tears, saliva, and breast milk. IgM is 8% of the body. What is that? First line, G-A-M? Oh, IgD. I thought it said O, and I'm like, there's no such thing. IgD is 1%, and IgE is like less than 1%, like 0.0002% of the body. Table 14-5 on page 214 in your Lewis book details these immunoglobulins better.
Do you want us to know?
All right. Hypersensitivity reactions. These are important. You need to know this whole chart. Type 1 is immediate. It's caused by IgE. Clinical manifestations are anaphylaxis, angioedema, and urticaria. So anaphylaxis is like the worst allergic reaction. Throat closes, they need to be intubated. Angioedema will occur where the whole face is swollen, eyes are shut. Urticaria is just raised hives on the skin. Type 2 is cytotoxic. Mg are the immunoglobulins that are affected the mechanism, and the manifestations include cytopenia and nephritis. So the kidneys are going to be involved. Type 3 is immune complex. M and G are involved. Serum sickness and vasculitis can occur. Or those are an example of an type 3 immune complex reaction. Type 4 is a delayed reaction. It's T lymphocytes, and it's contact dermatitis. T cell mediated. And then other would be idiopathic, it varies, and it's a non-specific rash. So it's a rash of any kind. It usually occurs with pediatrics, like all these generalized urticaria, pruritus, like all these different allergic reactions. A good way to remember this, type 1, 2, 3, and 4, is A, B, C, D, allergies, blood, complex, delayed. Because A is type 1, allergies. Anaphylaxis is going to occur, that's an allergic reaction, angioedema. B is blood, cytotoxic, it occurs in the blood, nephritis and cytopenia. C is type 3, which is complex, immune complex, serum sickness and vasculitis. And then D is the delayed type, type 4. It's T-cell mediated, and an example is contact dermatitis. It's just an easier way to remember, like instead of type 1, type 2, type 3, type 4, A, B, C, D. Anaphylaxis. Signs and symptoms of anaphylaxis include swelling of the conjunctiva, which is the white of the eyes, or conjunctivitis, runny nose or rhinoritis, swelling of the lips, tongue, and or throat, central nervous system, lightheadedness, loss of consciousness, confusion, headache, anxiety. Respiratory, you're going to see a lot of wheezing, shortness of breath, maybe some hoarseness because the throat is closing, the airway is closing, pain with swallowing, a lump in the throat or itchiness on the tongue. A cough may occur as a response to that. The skin you may see pruritus, urticaria, papules, hives, flushing, itchiness. Sometimes it may even be pelvic pain. Bladder control may be lost. Diarrhea and vomiting. It's a severe multi-organ reaction, progresses rapidly, can be fatal in a matter of minutes. These patients that know that they're allergic to a specific thing, like some kids are allergic to peanuts, or some people have like really bad hay fever where they get outside, the pollen is so bad it can cause an anaphylactic reaction, or be really bad asthma. They will carry an EpiPen with them just to delay their anaphylactic response until they get their corticosteroids and their anti-inflammatory medications and hospitalization. This is IgE-mediated response. You're going to administer epinephrine, whether it be intramuscular, subcutaneous, or intravenous. The most important part of the anaphylactic reaction would be to protect the airway. You want to, if the person is swelling, you want to intubate before it swells up till you can't intubate and you can't get that airway. If the patient is just complaining of maybe some itchiness on the tongue, you want to put an oral airway or a nasal trumpet at the bedside with an bamboo bag just to prepare for an emergency situation. Because it is inevitable if they have an anaphylactic reaction and they're not treated for it, everything will close up. This is an example of a PEDS case of angioedema. Do you ever see Hitched? With Will Smith, that was like the beginning of the anaphylactic reaction, but it never occurred because he got the Benadryl. Well, and it's a movie. But he almost had angioedema on one side. Maybe accompanied by hives. It's a result of a histamine release. Angioedema can progress to anaphylaxis quickly. The treatment is antihistamines. An example of antihistamine would be Benadryl, diphenhydramine, and corticosteroids, so prednisone or solumedrol. Protect the airway. Remember ABC, very important. Swelling begins in the face and progresses to the airway. Very fast. Type 1 reactions, allergic reactions. There's skin, upon contact, poisonous plants, poison oak, ivy, poison sumac, as a result of animal dander or sometimes animal saliva, pet saliva, pollen in the environment, or latex allergies with patients in the hospital. Mostly everything is latex-free in the hospital now as a result of that. Injection reactions would be bee sting or medications that are injected. Ingestion reactions could be medication. Some people are allergic to all sulfa medications. Nuts and shellfish ingestion. Inhalation could be pollen also, maybe some dust, mold and mildew, and once again animal dander. Atopic reactions could be eczema, allergic rhinitis, and that allergic rhinitis is just a runny nose with clear fluid, so it's not infectious whatsoever. That's allergic rhinitis and eczema are a predisposition for asthma. So people who have eczema will most likely develop asthma in the future or already have it. Elevated IgE levels, chronic exposure to antigen plus it could be hereditary. The treatment would be local anti-inflammatory medications, so maybe like hydrocortisone cream or something. Page 455 in the text I have written down, so it must be something important about an atopic reaction. Type 2 reaction, acute hemolytic reaction. Main symptoms include chills and fever, tachycardia, chest pain, low blood pressure, heat sensation in the vein it's infusing, pain in the lower back, in the lumbar region, hemoglobin released into the urine, and high bilirubin levels. Acute renal failure may result because of this, and that's because of the hemoglobin in the urine. This is a common blood transfusion reaction, and it's because of ABO incompatibility. It's mediated by IgG and IgM. Red blood cells, platelets, and leukocytes are the target cells that are affected. Goodpasture syndromes, pulmonary hemorrhages, and glomerulonephritis. This is what occurs with severe acute hemolytic reactions. So you're going to have an acute hemolytic reaction. That's the most common type of reaction you will have to like a blood transfusion. So Goodpasture syndrome, if you're ever questioned about that, affects the lungs and the kidneys. Type 3 reaction, serum sickness, fever, chills. It could be from the diphtheria, tetanus vaccine. Stevens-Johnson's disease. It's a reaction to sulfa drugs. Lupus, rheumatoid arthritis, acute glomerulonephritis, vasculitis. IgG and IgM complexes form and deposit themselves on various organs. The most common organs are the kidneys, the joints, the skin, the lung, and the blood vessels. Type 4, T-cell attack the antigens. This is contact dermatitis. This was that picture in the last lesson of with a little dragonfly. It must have been like a tattoo or a sticker on the skin, and then the hives or the pruritus just develop in the area where it was contacted. It could be as a result of cosmetics that you're allergic to, poison ivy, poison oak. Treatment involves corticosteroid local administration, such as a hydrocortisone cream, 1%. And a PPD test for tuberculosis can also cause a contact dermatitis, which would be T-cell mediated. Skin testing. You want to avoid the use of antihistamines. You're going to have a RAST test, which is a radial allergosorbent test. It's a blood test. Patient needs to be observed during and after the test. An EpiPen should be at the bedside. These are usually done in doctors' offices. Drug therapy includes antihistamines, such as the ones that block histamines, which is Benadryl. Decongestants, like alpha or beta receptor stimulators, like epinephrine. Corticosteroids, such as prednisone or Nasonex. Antipruritic drugs would be like over-the-counter calamine lotion. You can put that on like poison ivy just to stop the itchiness on the surface. And then mast cell stabilizers prevent histamine release from the mast cells so they stop the allergic reaction in its tracks, and that's an example of cromulin. Immunotherapy. Used for patients with chronic allergies. Administration of small titers of an allergen extract in increasing strength until hyposensitivity is achieved. When this administration is occurring, an EpiPen should be available. And 20 to 30 minutes after the injections of the allergen, the patient needs to be observed, just for anaphylactic response. On to blood transfusions. This would be a continuation of anemia. So ABO typing and blood transfusions. Does everyone know their blood type?
Yes.
It's good to know. O negative is the universal donor, and AB positive is the universal recipient. So AB positive blood type can receive any type of blood. And then O negative, everyone can receive O negative blood if they need it. Blood component therapy is only temporarily supports the patient until the underlying problem is resolved. So if they have a GI bleed, you're going to be administering them tons and tons of blood and isotonic fluids. However, that's never going to resolve unless they cauterize whatever the GI bleeding is going on or surgically fix it. Stop the anticoagulant if necessary. You don't want to give them a blood thinner if they're bleeding. You have to be culturally competent for patients that are Jehovah's Witnesses, because they, according to their religion, they do not or cannot receive blood transfusions. So they will be a part of something called a bloodless program. And these physicians work in this bloodless program to do everything and anything they can do besides a blood transfusion for severely anemic patients that are observing this religion. I don't know if observing would be the right term, but you know what I mean. There are eternal consequences as a result of this. So they would have, like, if they're iron deficient, they would have extra iron supplementation and be monitored closely, have frequent blood tests, which will kind of contradict because they need that blood, but they have to test their levels. So in addition to ABO typing, to find out what type of blood is AB, A, B, O, you need to do Rh antigen testing. And that's just to see if it's positive or negative. You'll get, you will, hold on. You'll get more familiar with the Rh antigen when you do OB, because a pregnant woman who is Rh negative needs to receive something in their 28th week of pregnancy to counteract that whole thing if the baby may be positive, because it is possible for the baby to be Rh positive, and then the antibodies will work against each other, and the mother's antibodies will fight against that antigen, and it'll be a whole big mess. And when the blood crosses, it doesn't cross the placenta, but when it eventually does cross, it can cause problems in the fetus or any babies in the future. I don't know why I can't think of, I know why, I'm tired, but the medication that they would get.
Is it Rogam?
Yeah, Rogam, thank you. So it's RHOGAM, Rogam. It's Rh positive. It will be given to Rh negative pregnant women in their 28th week of pregnancy. to combat it, just in case their child is Rh positive. I have a friend who did not, for some reason, receive the RhoGAM shot. Not to her knowledge. I don't know. I don't know if she was aware of it. And her child, I don't even know the name of the disease her child had, but she lived for only 7 years. She just recently died last year, but she can't have any other children because she didn't receive that RhoGAM shot. And I know for sure it wasn't her choice. She just wasn't aware of it. And her baby was positive, and it affected and built antibodies in her system where if she ever has any other child, her body will just kill it. So in utero. So she can't have any more children, and her child just died. It's horrible. So it's really important that you know your blood type, especially if you're a woman, and you plan to have children in the future. Just in case you're negative, you need to get that injection. If an incompatible blood is transfused by mistake, the patient will experience a reaction, and it's lethal. They could die. Before any patient receives blood or any type of blood product like FFP, which is fresh frozen plasma, or platelets, the patient needs to be typed and crossed, blood tested for ABO group and Rh compatibility. And they usually do it twice within a few hours of each other, just to make sure, because blood can be mixed, vials can be mixed, mislabeled, human error. But at least it was positive to positive, and not like you were negative and you thought you were positive, because that's the Rh antigen is more important.
April Fool's that never happened. No,
Oh, I forgot about April Fool's. I would have did something. The test is today. No. All right. Types of blood product. Packed red blood cells could be frozen. Red blood cells used for acute blood loss. Pooled platelets are used for thrombocytopenia. So you want to know what type of blood product you're going to give for what disease process. So pooled platelets are used for thrombocytopenia. Packed red blood cells are used for acute blood loss. FFP is used for clotting factor deficiency. Plasma expanders are used, such as albumin from plasma, are used for hypovolemia. One unit of packed red blood cells is about 250 to 350 milliliters. Examples of thrombocytopenia would be vitamin K deficiency, hemorrhage, examples of why you would have thrombocytopenia would be as a result of vitamin K deficiency, liver disease, excess coumanin in the body, hemorrhage, or DIC. So this is just... really close today. You'll get plasma or albumin from plasma when the patient is in hypovolemic shock. When you centrifuge, if anybody's seen a centrifuge, it's where they put it in that machine in the laboratory and it swims around really fast. When you centrifuge 500 milliliters of whole blood, you'll get about a unit of platelets. And that unit of platelets is about 30 to 50 mLs of yellow-colored blood product. Something called platelet pheresis is when the platelets are taken out of one donor, and then the rest of the blood is put back into the donor. So the whole blood is reinfused into the donor. They just take the platelets out. 1 unit of red blood cells could increase the hemoglobin up to 1 gram per deciliter, or increase the hematocrit by 3%. A blood transfusion cannot be mixed with any other IV fluid except for normal saline. This is where the hemolysis will occur. I think I mentioned this before. So if you're putting this, you have to do like 2 bags. Here's the unit of blood, And then here's the bag of normal saline, whether it be 500 milliliters or 1 liter. It's really, as long as it's at least 500 milliliters, you're good. You want to prime the tubing, which is Y tubing, and then you infuse the blood. You don't want to prime it with blood because you don't want to waste a drop. So you prime it with the normal saline, and then all the blood gets into that patient. And once all the blood is infused, you clamp that, and then you let the normal saline infuse, so all the tubing gets in, because that tubing could be like 5 cc's, or up to 5 milliliters of blood that's stuck in the tube. So you want to just get all that normal saline in. Most of the time they need the volume anyway. If the patient is a renal patient or a CHF patient, and they can't have the fluids because it's contraindicated, they may even receive Lasix in between transfusions. Or they may receive the minimum fluid to prime the tubing, which would be like 250 mLs of normal saline. So you need to know that you cannot put dextrose or any type of hypertonic solution with a blood transfusion. It can cause hemolysis and ruin the blood before it even gets into the patient. You need a large bore needle. Vital signs needs to be done before, during, and after the transfusion. And during is usually like 15 minutes into the transfusion. It says here it's administered on a pump within 4 hours. No, it's not. I've never put blood on a pump and infused it in my life. It's not because the blood pump wasn't available. I've never done it. You'll never do it. If you do it, it's probably because I don't know. Maybe because it's high tech now. I don't even know what to say. You're not going to do it. Just know that the blood, that once you start infusing it, it needs to be transfused within 4 hours. Otherwise, it's no good. Anywhere greater than 4 hours, there's an increased risk for infection to arise within the transfusion bag. You want to do some type of, it's called the dual checking system, where you get the blood from the blood bank, you bring it up to the patient's bedside, you're going to check according to the patient and the patient's identification wristband, as well as their blood type band, with another RN or another licensed professional. So it'll be an RN, a PA, a resident, or a physician. So it has to be a licensed professional. But it used to only be a doctor to a nurse. Now it could be a nurse to a nurse. So you both check the identification together at the bedside with the blood type, and then you look at the blood bag, the right tubing, the right patient, the right expiration, the right type, etc. The right blood type. The rule of thumb for the rate of infusion of a blood transfusion is about 2 mLs per minute. If you don't start the infusion within 30 minutes of receiving the blood from the blood bank, you have to bring it back to the blood bank. Even if you have to administer it cold, sucks to the patient, but at least you know there's no infection. You want to just want to clarify, because I will be asking a question related to what you do with a transfusion reaction with a blood transfusion. You want to know that in the text, it does mention a list of the things that you do. Just know in the text, it's not in the order of priority. So if an acute reaction occurs, you want to write this down so you get an easy 2 points. You want to stop the transfusion. Assess the patient's vital signs. Notify the provider. Disconnect the blood tubing and send it to the lab. That's one. And then document the incident. So documentation is always at the end. Worry about that later. You could jot it down on your hand, whatever you have to do, write it down and officially document it later on. That's the last thing you do.
Is that in order person? Or is that like a pipe?
I think I gave you enough. Alright, so stop the transfusion, number 1. You always, now aside for what I just told you always want to recheck the bands. Make sure you have the right patient, you're infusing the right patient. Recheck whatever you checked with the dual checking. That's going to be done. You always want to save the blood tubing, the blood bag, the normal saline bag that you primed it with, the bag that you brought up the blood with, the papers, the vouchers, everything that touched the blood, near the blood, came up from the blood lab, the blood bank with you. Everything gets saved and sent down. They test everything. They're actually, afterwards, you're going to be drawing the patient's blood and taking urine to make sure to see what type of reaction is occurring. The blood bank and the lab are actually responsible for determining the reason for the reaction. You treat the signs and symptoms of the reaction as per the physician's orders. Always maintain a patent IV. These are the different types of blood transfusion reactions. Acute hemolytic is the most common, that's why it's at the top. Clinical manifestations include fever, chills, back pain, a feeling of impending doom. Common mechanism is ABO-compatible red cells are given to the patient, so it's the wrong type is given. Treatment is pressure and volume support. And then prevention would just be to carefully identify the patient, carefully identify. If it's done in the blood bank, you can't avoid it. But what you can prevent is giving, if you know your patient's O negative and then you're looking and it says A positive, you know that's wrong on the bag, so then you would stop it there before administering it. Just know that anyone is capable of making a mistake, no matter how perfect they are. We're all human. Sometimes patients with such as the febrile non-hemolytic reactions, they've had them in the past, they're anemic, they get transfusions often. If you know something like that, the doctor may prescribe an antipyretic prior to administration to avoid the fever and the reaction that will occur. So maybe they'll get Tylenol, maybe they'll get Benadryl and Tylenol 30 minutes prior to the transfusion. So this is the cartoon, the blood transfusion reaction. Somebody's calling for help. Intervention. Assessment number 1, the nurse arrives and quickly assesses the situation as a blood transfusion reaction. You see the MD is notified over there. The blood tube is disconnected and saved for lab eval. IV is clamped, turned off, and the blood transfusion is stopped. The normal saline is hung using new IV tubing. So you have the normal saline up. You would think just clamp the blood off and run the normal saline. No. Because you got that full long tube of at least 5 cc's of blood already. So what are you going to stop the transfusion, let that go through, and then let the normal saline go through? No. It could be the tubing that's contaminated. So you want to take the whole thing, disconnect the whole thing. You can use the same IV. Just flush it and then instill normal saline. Vital signs, oxygen saturation, lung sounds are checked. Documentation is done at the end. Nursing management. A blood transfusion is against some of religious beliefs, like I mentioned. Start an IV with a large bore needle. Normal saline should be primed and hung. Doctor's order for transfusion. Very important. Along with the doctor's order, you also need consent in the chart by the patient. Even though they're sitting there accepting the blood through their IV, they may not have signed a legal consent, and that's on you. It's the doctor's responsibility to obtain consent. He should order the blood after he obtains consent and it's in the chart. But once again, you're the nurse, and who's going to be responsible? The nurse, because she didn't look to check if the consent was there before she started administering the blood that was ordered by the doctor. Wrong. Separate consent from needs to be formed, which needs to be signed. Always 2 people that hang the blood, RNs or RN and MD. Never use a UAP. Doesn't say anything about an LPN though. Stay with the patient the first 15 minutes of the transfusion. Sometimes the patient will be pre-medicated, like I said, with Tylenol or Benadryl. You want to measure the urinary output hourly, especially if there's an acute hemolytic reaction. So, complete opposite. HLA typing. Human leukocyte antigens are present on all nucleated cells and platelets. Used for matching transplant donors and recipients. Speaking of transplants, certain HLA types are linked to certain chronic diseases. The degree of HLA matching is required, or I don't even understand my own handwriting, or declared suitable for successful solid organ transplantation is dependent on the type of organ. I don't know what that means. Alright, after this, I'm going to fall asleep. The patient is evaluated for possible atopic dermatitis. The nurse will review the patient's laboratory values for the level of what? It's A, IgE. To prevent anaphylaxis after a patient has received allergen testing using the cutaneous scratch method, the nurse should initially monitor the patient's arm at the site, maybe some type of allergen contact dermatitis. Alrighty, I hope you got everything in. I'll do a brief review and then we'll start respiratory on Friday.